You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Hi, everyone. Welcome back to the Pediatric Pharmacist Review. I am one of your co-hosts, Justin Cole, and I am joined again by our immaculate stand-in co-host, Mary Vuong. Mary, you are with us today on this, and you're kind of navigating two sides of the mic today. You're essentially a co-host and a guest, so I'm excited to see how you navigate this. But Mary, thanks for joining again today.
Thanks for having me. It's kind of like I'm Hannah Montana today, just out here living the best of both worlds.
You are, yes. Flexible. If there's anything I've learned about Mary, it's that she is like a chameleon. She can do nearly anything. So it's a blast to have you back on the podcast. And I'd love to have our guests go ahead and introduce themselves. Today, our topic is pediatric dysphagia, and we've got some speech and language pathologists joining us. But let me stop talking and let them introduce themselves. So first, Brooke Richardson. Would you be willing to tell our guests a bit about yourself?
Hello, everybody. Thank you for listening and thank you for having me on this podcast. I am Brooke Richardson. I'm a medical speech language pathologist working with adults, primarily in the acute care setting with various disease processes and illnesses and injuries. And I'm really excited to be here today and learn from my colleagues and hopefully share some insights as well.
Well, we appreciate you joining us, Brooke. Thank you so much. Bree, I'll let you introduce yourself as well.
Hi, thank you so much. Thank you, Justin and Mary, for having us on here. I'm Bree Millick, and I'm a speech language pathologist. I primarily serve infants and medically complex kids in the community-based setting. So I typically go into the homes with families into kind of that more natural environment, which I really, really enjoy. And yeah, really excited to be here and talk about this topic. I think it's really important when we are looking at pediatric feeding and swallowing and considering not just the medications our patients are on, but how that then plays a role in their swallowing. So I'm excited to be here. Thank you.
Thank you both for agreeing to join. You're actually the first speech language pathologist that we've had on the podcast. So that's an awesome win. We're definitely looking for like a wider range of healthcare professionals because it's like we're a team. It's nice to just learn everyone's different perspectives and like work together because we all fit into this puzzle for each special patient.
Absolutely.
Well, all of you were co-authors on a recent paper that was focused on dysphagia. So I would love to start by simply asking, what inspired each of you to be a part of writing this recent article?
I think I was kind of looped in through my mentor, John Coakley, who was on this podcast as well a few months ago, but he is always looking out for me and he's like, this is a great topic for you. Like, would you like to join in on this paper? And I was like, sure, why not? And I joined in on the review paper. It was very cool working because it was a team of doctors, speech language pathologists, nurses. So it was like a true multidisciplinary review paper and everyone had great insights and we're just like working hard to get this paper done. But I think, Brooke, you were involved originally, if I'm not mistaken.
Yes, that's right. Yeah, I got looped in by Dr. Rubinos, who is a neurocritical care physician. We actually worked together. So really, really neat to be able to participate in this paper. And the biggest part for me was, like you were saying, Mary, the teamwork and having this be an interdisciplinary effort, because that is so, so, so important for our patient care. And it's really exciting to see it actually translating over into articles and papers, and to see this happening outside of the clinical setting, and hopefully to help people across all disciplines really embrace and really love and feel empowered by being part of a big team.
I totally agree with that. And I think the paper is something that will be really important for the literature, because dysphagia is something that's overlooked. So that kind of like leads me into my first question. Why do you guys think dysphagia is overlooked, and what are signs that people should look for?
That's a really big question. I can I can speak from my perspective with adults, whether it's from in outpatient or in acute care, but I think just a lot of people get used to feeling how they feel when they eat. So some people might not realize that something feeling stuck somewhere or coughing when they eat or something like that is something that they should be concerned about. They may not associate their weight loss, which maybe they wanted to lose weight, but maybe they're losing weight because they're having a swallowing problem. They may not associate it with a swallowing problem. So I think from an adult perspective, that's why it tends to be overlooked. And we swallow, I don't even know how many times a day. I can never keep that stat in my head. I wish that I could. Maybe Bree knows it. But we swallow so many times per day that it's very easy, I think, for our nervous system to just acclimate and adjust. And then as far as signs people should look for, there are a lot of different signs of swallowing difficulty. One might be coughing and choking at meal times. One might be the feeling of something getting stuck in the throat or in the chest. There are different kinds of swallowing problems too that can happen anywhere, essentially from the lips to the stomach. So we've got this whole long GI tract where pretty much anything can happen. So those are a couple of bigger signs of swallowing difficulty that people might want to look out for.
I'm going to hop in and kind of tack on to the pediatric side now. So to answer your question, or Brooke, your comment about how many times we swallow, it's like between 900 and 2,000, I think is like the stat. So it's, it's a huge amount. But I think with pediatrics, kind of, just like Brooke is saying, there's some of these less overt signs when we think about dysphagia. So I think a lot of times when people think, oh, I'm having trouble swallowing, I'm coughing. Every time I swallow, I cough. And there's so many other symptoms that could signal that there is something going on with swallowing that's not coughing. So I think for like general public awareness of what dysphagia is, recognizing that there's some less overt signs. And if we're looking in pediatrics, the coughing reflex really doesn't even come about until 52 weeks postmenstrual age. So those first couple of months of life, we might not even see a cough at all. You add in other factors like prematurity or neurological implications, and that cough reflex may not come about for a really long time. And so then we're looking at some of those other things. And with peds, I think one of the reasons it's so overlooked is an infant or a young child or a non-speaking child can't say, I don't like the way it feels when I swallow. I'm uncomfortable. Something doesn't feel right. And so if we are not careful to monitor for some of those other less overt signs, like red watery eyes, unexplained respiratory illnesses, we're having trouble with identifying some of those less overt signs, it can be even trickier and it can be overlooked because of that. And I would also say, like Brooke said, sometimes I have found that like children that are having trouble with weight gain, sometimes that is the only sign we see. Or sometimes we see a child that has an oral aversion and we're like, oh man, why are they so aversive? Is this a sensory issue? When in fact, they're learning to say, it doesn't feel good. It doesn't feel right when I swallow and I'm uncomfortable. So I think that really plays a role in pediatrics. In terms of kind of the second half of that question, what signs should people look for? when we think about a pediatric feeding disorder, so like pediatric feeding disorder is the diagnosis for feeding and swallowing problems. And it really has four main domains. So we have a medical domain, we have a nutritional domain, we have a feeding skill domain, and then we have a psychosocial domain. And the medical domain is really where we're thinking about dysphagia. So this is a child who has neurological implications, cardiorespiratory implications, or gastrointestinal implications, and really screening for those areas. And it may not be as like the pediatrician or, you know, the primary care provider that this child is seeing may not be the one to say, yes, you know, this child has dysphagia, but being aware that having those, any diagnoses within those areas or any difficulties within those areas may place the child at higher risk of having dysphagia. And so then from there you can say, hey, maybe we do need to send that referral over and we can get a little bit more information on the child's swallowing status. And I know we're going to talk about this later, but really that comes down to like an instrumental evaluation of their swallowing. It's not something we can diagnose bedside. So we're more so looking for those signs and symptoms that say, hey, I think we need further testing.
Bree, you did a great job of outlining the various domains that are impacting dysphagia, particularly in the pediatric patient. So maybe to get a bit more practical for our listeners and help to just paint a picture of dysphagia, I'm curious if the two of you can talk about how dysphagia affects the patient and their family and their life just practically.
So like I said, we have those four domains, right? So from a medical standpoint, that's obvious, right? It's affecting their health status. It's affecting medically what's going on. This may make it more difficult for a child to participate in certain aspects of life. And then we have feeding skill, which is like developmentally, are they advancing their skills? Can they chew and swallow all the things that they're supposed to? Nutritionally, are they meeting their nutritional needs? But the area I really want to emphasize with this is the psychosocial domain. And it's one that I think is oftentimes overlooked, but I would actually argue being the most important one to consider. And when we think about the psychosocial domain, these are going to be factors that influence the child and the caregiver. And if for example, you have a child who has swallowing difficulties, it's causing stress on the caregiver because they're having to maybe prepare liquids differently, or they're worried about, is daycare going to be able to prepare it in a way that's safe for their child so their child's not getting sick? That stress or distress that the parent is experiencing can then influence the caregiver and child interactions and the attachment and all of those other factors that are so important to growing and developing in childhood. And, you know, this can also start to look like, the caregiver, there's a mismatch between the caregiver's expectations of what the child should do and what the child is actually capable of. This can lead to things like the child feeling left out at birthday parties, at school functions, at, so many other aspects. And I'm going to pronounce the name wrong. I'll look it up, but I think it's Rosenbaum. There's an article called F Words of Childhood Disability. And it basically takes like the ICF, like the WHO's ICF framework, and reworks it into how to think about it in pediatrics. And one of those F words is fun. And recognizing that fun is such a crucial part of childhood and quality of life and development, and thinking about how dysphagia can influence the child's ability to participate in all of those activities that are so crucial to being a child. And I think that's just a nugget. I love that article because I think it's just like a really cool framework to look at it from a pediatric lens. But I think that's kind of the biggest things, is recognizing that it affects both. And by affecting both, we see psychosocial implications that can carry on in a lot of different areas.
Yeah, it's interesting, Bree, how much overlap there really is across the lifespan, right? You and I are specialized in swallowing in two very different ends of the spectrum. So I see it from maybe teenager all the way to end of life. But there is a lot of overlap. And I think the medical part, there's overlap, right? We talked about weight gain, weight loss, chest congestion, comfort, discomfort, all of those things. But the psychosocial part is so important. Fun is important for adults too, but I don't think we give it enough credit, and we don't have as much fun as we did when we were kids, but it's really that social engagement and involvement, right? So if I have somebody who can't swallow and they have a feeding tube and they have to carry their formula around, and they can't have the hot dog at the baseball game with their friends, it's the same concept as it is in pediatrics, where they feel like they're a burden. They feel embarrassed. They don't want to go out because they don't want to have to stop and pull out a syringe and give themselves nutrition through a feeding tube. If they're still eating by mouth at all, but there's somebody who coughs and chokes and hawks things up because they have a history of head and neck cancer, but they're still going to eat by God because it's so important to them and it's part of their quality of life, even though it's really, really difficult and unpleasant at times, then sometimes they won't go out to eat with friends or family because they get so embarrassed about coughing things up at the dinner table or having to excuse themselves to go to the bathroom. And then, of course, there's a lot of these pressures as far as making decisions around eating and drinking for somebody who might be at end of life, might not be, but especially at our end of life folks where there's a natural process, a disease process, or just the aging process that's making it difficult for them to eat and drink. Then there's a lot of pressure for them to make these decisions or for their family members, loved ones, care partners to make decisions around eating and drinking, because then there's this whole thing of, if we have them eat and drink and they cough and choke and they get aspiration pneumonia and die, then I've killed my loved one. But then there's this other part where if we don't allow them to eat and drink, then I feel like I am starving them to death. And I think that's, I don't know much about the pediatric stuff, but I'm a mother myself and I took one pediatric feeding class a long time ago. And I know how important it is across the lifespan to feel like you're nurturing someone, and eating and drinking is such a huge part of that.
Yeah, you both mentioned this idea that food and nutrition are so integral to social connection. We often think of it from its biological need for our bodies, but throughout all of human history, eating and our relationships have been intertwined. So it's fascinating to think about the vast span that dysphagia can have in terms of the effects. I also think about some of our kiddos with neurologic conditions. I think, Bree, you've kind of alluded to this. Some kids that come to mind are those that are diagnosed with cerebral palsy, or higher risk of dysphagia, of course, in that population. And it can be a challenge for caregivers, not only related to the nutrition, but simply management of oral secretions. We take for granted the fact that we often can swallow easily and manage those. But in some of our kiddos with cerebral palsy, that itself is something that caregivers have to deal with every single day. So, so many insights here. I think we could just pause and talk about this all day, but we want to move on to some other things. So I'd love to just find out a little bit about some of the ways that clinicians screen for dysphagia. So maybe, Brooke, you could tell us at a high level what's done in adults, and then Bree, maybe you can follow up and give us a pediatric flavor on that.
And I guess my additional question to this is, as a non-SLP, like if I am working up a patient in the hospital or in the clinic, like what are things that I should be looking out for as a pharmacist or like as a nurse or something to say, hey, this kid needs to be eval'd by an SLP?
Great question. And I'm happy to talk about the adult side and things people can look out for there as well. I'll start with that actually. Is a lot of times people do expect to see some sort of coughing and choking. And sometimes that is the case, but as Bree mentioned with kids, the same thing can happen with adults where there's not coughing and choking, but there can be this you get this little spidey sense when you're watching them and they when they swallow something just doesn't feel right. And maybe it's that they grimace, or maybe it's that they look like they're working really hard to swallow something. Or maybe they sit forward a little bit. Sometimes there are these just really subtle pieces of body language that you might notice when you're observing somebody swallowing. Maybe they take a sip of a juice or water from their bedside tray and you see something. Or maybe they do report symptoms of difficulty swallowing pills, which is sometimes our professional bread and butter as far as referrals can be concerned. And difficulty swallowing pills, things getting hung up, feeling like they're losing weight, feeling like they get full really quickly. So if they report anything like that, or if there's anything you observe, it's never going to hurt to go ahead and proceed with a referral to speech pathology. And then we can take it from there and say, yeah, they're at risk. Let's go ahead and evaluate, or maybe not so much. We can talk about this further. So there's screening for dysphagia and there's evaluation for dysphagia, and they're two distinct things. And sometimes the screening for dysphagia is done by a speech pathologist, and sometimes it's done by another member of the team, like a nurse. So the screening process typically involves looking at very, very briefly at the cranial nerves. It's not a very in-depth examination. A mental status examination to see if they're oriented, giving them 3 ounces of water to swallow to see if they can swallow without stopping and swallow without coughing or choking for about a minute after they drink those 3 ounces sequentially. That's a fairly sensitive test, but it's not perfect, and that's why it's a screener. And then we have the clinical swallow evaluation, which is done by speech language pathologists, sometimes actually other disciplines, depending on where you are in the country and what country you're practicing in, but primarily speech language pathologist, where we do an in-depth examination of the cranial nerves, of sensation, of oral function. We may incorporate that 3-ounce water swallow into that evaluation. We may watch them chew and swallow various consistencies. And I have to say, this whole thing really starts with a very in-depth look at the patient's medical status. We absolutely have to incorporate this big body systems approach into our evaluation. So we're not just going in and looking at the person and feeding them. There's a whole lot that's going into this evaluation. So we don't have X-ray vision at the bedside. Unfortunately, we have not developed that yet. So we can do further testing either through FEES, which is fiber optic endoscopic evaluation of swallowing, or modified barium swallow study, or video fluoroscopic swallow study. And the FEES is done through nasendoscopy at the bedside. It gives us a superior view of the pharynx and larynx, so we can see a little bit about oral phase, but it's primarily pharyngeal phase, to see how things are clearing through the pharynx and how well the person is avoiding getting anything into their airway that shouldn't be there. And if it does show up, can they cough it out? Whereas the modified barium swallow study allows us to see a lot more of the oral phase. It also allows us to better screen the esophageal phase, which is very, very important. And that gives us a lateral and also AP view of swallowing function under fluoroscopy. And that is done when they are drinking barium.
Yeah, so I'm gonna Brooke gave a really good comprehensive overview of evaluations, and we look at very, very similar things in pediatrics, but I'm going to provide a little bit of a spin, or the nuance to peds that comes into play here. So first, from a screening standpoint and thinking about other clinicians screening for dysphagia, there's different things that we may see being reported. And I would say that's the biggest thing with peds, is that we are relying super heavily on caregiver report. We are going to, of course, have some observations of feedings and what they look like, but a lot of the times we don't have a patient who can tell us how they feel or what's going on. So we're going to rely pretty heavily on parents. And so we might be asking for things like, notice any breathing difficulties with feeding? Does your child start to breathe more heavily during feeds, or does their breathing quality change? Does it start to sound a little bit wet or gurgly? Do you notice they sound more congested during or after feeds as compared to at baseline? We might be looking for things like even just child becoming upset during feeds. Do we notice like face getting red, watery eyes? Of course, coughing is a big one, but like I said earlier, may or may not be present. We might be seeing the child who isn't really showing much during a feed, or parent aren't reporting very many things. However, their child has respiratory illnesses pretty frequently, and it's not like no one else in the family is sick. They're not in, daycare where they're getting sick a lot, or when they get a cold like the rest of the family, it takes them a lot longer to get over it as compared with their siblings or their parents. Also might look like even like gagging really frequently during feeds. So again, may not present as a cough, but more of a gag. Also again, kind of going back to the breathing changes, any like sturders or striders. So really like high pitched or like lower pitched, like gurgly, snoring kind of sounds during feeds as well. So those are kind of some of the things you might like be probing for and looking for, but from there, it would go into observations about all the things that Brooke just talked about, like watching during a feed. Do we notice any of those things? Now, from a screening standpoint, I kind of say like there's not really one single symptom that would tell me, even during a comprehensive evaluation, this patient needs a swallow study. They need to go for an instrumental, because I really have to look at it whole picture and what's going on. And so I'm thinking like medical history, feeding history, and then observation to tell me. But for other providers who are unsure if they need a more comprehensive evaluation, I always say, like, when in doubt, refer out. Refer to the SLP and let them do that comprehensive evaluation to then determine the next step. I would much rather you send me a child who I say, hey, you know what, actually, I think we just need a small modification and they're good to go, than miss the child who really was showing signs that were just less overt and weren't as obvious to someone who's not well trained in dysphagia. There is a really cool screening tool that was developed by Feeding Matters. It's called the Infant Child Feeding Questionnaire. It's for children under 4 years old, but from the 0 to 4 range, it's really, really good. It's 6 questions, and it's basically saying if a parent responds in orange, is what there's like a gray side and an orange side. If the parent responds to 2 or more in orange, refer to a provider and go ahead and get that evaluation. Now that's for feeding and swallowing, but I think it's just a really good tool to be like, this takes 30 seconds, maybe less than, to run through with a patient to say, hey, I think we should maybe see another provider here. I'll also go ahead and say that ASHA, so the American Speech Language Hearing Association, recently came out with updated feeding milestones, and they're really, really good, I think, as well, for just like the quick screening of like, hey, is my child meeting some of these things, or do I maybe need to talk to someone? And so I tell providers it's really good to be familiar with those if you're concerned, and kind of just quickly pull them up and screen through them with your patient, or for caregivers to be aware of as well, to be able to say, hey, I noticed my child's not really hitting some of these things. I think maybe we need help here.
Yeah, I feel like dysphagia, and just like it's scary, because I've had those moments before where I'm like, oh my gosh, I felt like I swallowed that weird, like, is there something wrong with me? But then it's just because like in the hospital, I'm so used to like, oh my gosh, that kid needs a swallow study or this or that, and you just become hyper aware. But I feel like there's not enough awareness of it. So it's definitely something that will affect quality of life. And those tips are awesome, because I'm definitely going to look for that. And I think I will look up the questionnaire to see if that's something we could use for our patients, because I think swallowing is so important. So what are ways an SLP can help a patient with this condition? I know that you do the evaluation and everything, but is there therapy or different modalities that you both can tell us about?
Yeah, definitely. I'll go ahead and start here a little bit. And Brooke, I'm sure it's very similar. I think the biggest thing, or the biggest difference with peds and adult, is that I typically can't provide swallowing exercises, because a child does not understand them, can't follow that direction. Also, like the self-monitoring of like, make sure every time you drink, you use the skinny straw, or you do the head turn or the chin tuck. Yeah, no way. Like, I don't know any 3-year-olds that are self-monitoring that. So it's a little bit more nuanced in that. However, the principles behind what we do are very similar. So we look at task-specific neuroplasticity, motor learning principles to say, okay, in order to improve swallowing. In order to improve chewing, what do we need to do? We need to practice swallowing. We need to practice chewing. And so we need to do so in a safe manner. So typically, if I have a patient specifically thinking pharyngeal dysphagia, the first thing I do is make sure that oral care is established. We want to make sure that they have a good oral care routine in place, because we're gonna start to kind of play with some of these things, and we want to make sure that if they are to aspirate anything, again, I don't know, I don't have X-ray vision, but if they are to, it is at low risk as possible for actually causing an infection, that something's actually going to happen from there. Now, some of the things we can do are like diet modifications. So using thickeners is something that will come up a lot. We can also do sometimes just changing the flow rate of the drink or the drinking mechanism. So for infants, sometimes just going from like a level 1 nipple to a preemie nipple, or maybe they were on a level 2 and we want to go to a level 1, or we need an ultra preemie. So changing some of that, sometimes using pacing methods with bottle feeding as well can be helpful. But again, these are all things that we really need to test out on the swallow study to know for sure if it's helping or not. Sometimes positioning changes can also be helpful. But again, as a child gets older, the more difficult it is to implement those consistently, because like with an infant, we can put them in side lying and use pacing in a slower flow nipple. But in a 3-year-old, it's a very, very different experience. So taking that into consideration, with all of those things, we want to make sure to support the child's self-efficacy and autonomy as much as possible too. So if I'm working, for example, Justin, you brought this up earlier, a child with CP. If I'm working with a child with cerebral palsy and I'm like, using a straw cup is, we showed it slowed the flow rate just enough that like they were not aspirating on the swallow study. What I might do is make sure the straw cup I choose has handles because of the child's motor limitations. So that's going to allow them to still be independent while we work on that. In terms of actually treating the swallow, like I said, we want to practice swallowing. So if this is a child who's on thickener, we will typically work to start weaning that thickener away. There was this awesome study that came out of Boston. It's by Wolter and colleagues, and it was on the systematic weaning protocol. And basically what they did was they took a patient who was on a thickener, and every 2 weeks they reduced the thickener by 10%. They monitored signs or symptoms, and if they did well, they continued to decrease from there. And while that is just one study, I always say like that's just one study, so like everybody calm down, that's not the protocol we're going to do for every single patient. It considers motor learning and neuroplasticity, and that we can't just jump from moderately thick to thin liquid and just expect a patient to be able to do it. It takes what we know about, we got to make these small incremental steps, and hopefully you're using IDSI testing with your thickened liquids. But I'll always tell parents, I'm like, we're going to go from like the high end of moderately thick to the middle of moderately thick to the lower of moderately. We're not going to just jump from moderate to mild to slightly to thin. We're not even going to make that big of a jump. And this is where, clinical experience comes into play. I have some patients where I say, okay, the article again says 10%, but you've been on thickener for 4 years. I don't expect you to be able to make really big jumps because your motor process, your motor pattern is so specific to that. So we might do a 5% reduction. Or for some patients that it was something anatomical, they had a laryngeal cleft, had the laryngeal cleft repaired, they can probably move much quicker because now their anatomy is going to allow for the physiological standpoint of the swallow to happen. So weaning thickener is an example. We also do, and I'll let Brooke talk more specifically on what the Fraser free water protocol is, but in peds, we do sort of a modified version of it. So we might do some free water trials because again, we want the child to learn how to swallow thin liquids. So we need to practice thin liquids, but it's in a very, very structured manner. And it's going to look a little bit different from adults where it's not just free access at all times because again, kids aren't going to quite follow it in the same way that adults would. But really just trying to say, how can we slightly change what's going on now to advance them to where we hope to be? And another thing that's different sometimes in pediatrics, unless of course you're working with a more progressive diagnosis, is that we are typically working to make it better. Like it's habilitative in nature, maybe something that the patient never had the skill to do versus they lost the skill later on and we're trying to kind of bring it back. So a little bit different, but the principles of neuroplasticity and motor learning typically remain the same. But yeah. those are some of the things there.
I have to say, Bree, that you made me crack up a couple times because you were saying, oh, a 3-year-old won't remember to drink from the straw or won't self-regulate. I'm thinking, neither do my 73-year-olds. So it's sometimes adults are just big kids too. Some of the same, I don't want to say challenges because it's just reality, right? Like I'm an adult and I want to be treated autonomously and with respect and everything like that. So it's funny the overlaps that we have and how different it is too, where, yeah, when you're talking about a 5%, I'm like, a 5% what? It's usually for adults. Okay, well, we tried the thick stuff. You didn't like it. You know that there's potential risk of aspiration and pulmonary sequela from that, like aspiration pneumonia. We can try the thin liquids and see how it goes. So a lot of the principles are similar, though. You know, you talked about modifying diets, thickening liquids, and I do want to toss in here that that is not always the answer. And the pendulum swung really, really far toward everyone should be on puree and moderately thick, aka honey thick, very, very thick liquids. At least in the adult world, I see some nodding, so I'm thinking that probably happened in peds too.
Yeah, we want to avoid those extreme modifications as much as possible. And I would say the one comment I wanted to make about how you said, like, oh, if it's just not working, you don't like it, we'll just try thin and see what happens. The one caveat to peds is that the lungs are still developing, and we just aren't sure long-term aspiration what it would do. And so the risk to benefit is we have a little more that we have to kind of work with there. So we try to prevent it, but we try to avoid thickeners as much as possible first.
Yeah. And a lot of people don't really like the thickeners. I'd be curious to know in peds if that's kind of all they've known, if it's really not as big of a deal from a palatability perspective, but definitely the social perspective of why do I have to drink this thick stuff and my sibling doesn't or my friend doesn't. But yeah, sometimes, especially well-intended providers who aren't speech pathologists, who aren't as well versed in the risks and benefits and weighing that of modified diets and modified liquids, think, oh, well, thicker is safer, because unfortunately, I think a lot of speech pathologists back in the day kind of promoted that culture because there has been a lot of fear about aspiration and dysphagia. So there was this sort of culture and this belief that thicker is better. And now we're saying, maybe it's not. Maybe these really, really soft foods contribute to people not eating enough. And these really, really thick liquids make them experience early satiety. So they also don't eat enough. And they also have difficulty maintaining hydration. And they also have difficulty with processing medications because thick liquids can sometimes affect the bioavailability of medications. So yes, diet modifications and liquid modifications are a thing, absolutely. But I just wanted to put that really, really big caveat out there that if you feel that a patient might need a diet and or liquid modification, please refer to speech pathology so we can help to guide the patient in that decision-making process. And so we work with diet modifications, liquid modifications. Positioning is also important for adults. Feeding is important for adults. So if we have somebody, maybe they had cerebral palsy and now they are 25 years old and they've ended up in the hospital and are being managed by an adult experienced or specialized SLP in understanding positioning and feeding for that individual, but also for individuals who maybe have had a stroke and they're not able to use their dominant side to feed themselves, to brush their teeth, to provide oral care, or maybe it's someone with dementia or another advanced cognitive process where they're not able to feed themselves. There's a higher risk of aspiration pneumonia in people who cannot feed themselves, position themselves, and provide their own oral care. Those are risk factors for aspiration pneumonia. So identifying these risk factors is also really, really important besides dysphagia, in helping to educate the family, the care partners, the care team about how we can optimize the environment and feeding behaviors and things like that for adults, just like we might do as well in the pediatric population. And I guess that I can call myself lucky as an adult therapist because I can also recommend exercises that the patient may or may not do, right? Just like they may or may not drink thick liquids or drink from a specific straw or something like that. But we can try to target the underlying pathophysiology of their swallowing in hopes of improving the strength of the muscles, in addition to incorporating functional tasks like in peds, where we try to incorporate some sort of swallowing, eating, and chewing and make it more of a functional task so it's not just isolating something like strength.
I'm so glad you brought up thickeners because I feel like that is the most common question that as a pharmacist we would get in the hospital about dysphagia. Like, can we add the thickener to medications? Is it safe? And my question is always no, please don't do it.
Yeah, it's complicated because there is the standalone thickened liquid, right, that can affect the bioavailability of certain medications. Not all medications, but if somebody were to swallow a pill with honey thick liquid, then they may not get a therapeutic dose of that medication. But like you said, Mary, there are also these thin liquid medications that people might need to take, but they also have a dysphagia and they maybe need or they benefit from thickened liquid. So then this is where I love to have a conversation with the pharmacist and hopefully a physician or another provider member of the team, where we say, okay, we all have to weigh this risk benefit ratio together, because the last thing I want to do as an SLP is say, no, they can't have this really critical medication because it's not thick enough, because we don't know. Maybe the risk of developing any sort of aspiration pneumonia from that small amount of liquid medication is very, very minimal. And the benefit of potentially getting a therapeutic dose of that medication is much, much higher. So really taking that team approach and making sure that we all are understanding each other's perspectives of the risks and benefits, I think is so, so, so important.
Yeah, it's critical that we focus on this as a team. And so with that in mind, Mary, I'd love to hear a little bit about your thoughts related to your role as a pharmacist and how you can be helpful in management of dysphagia in pediatric patients. I think one of the maybe starting points that I think of is evaluating the medications for those that may worsen or lead to various degrees of dysphagia. I think anticholinergics, some of our behavioral health meds that we use in peds like SSRIs, and sometimes our antipsychotics can do that, some of our GI meds. But I'm curious, Mary, what is your opinion on what can a pharmacist do to be a part of this interdisciplinary team?
I think the role of pharmacists for swallowing difficulties is pretty vital as well, because there's so many questions that need to be asked when you think about medications and swallowing. So one of the biggest things that will come up is, can we crush this? So that's always something that I will always look into, either through ISMP's do not crush list or directly to the manufacturer, any sort of drug databases. Those are all great places to look to see if medications can be crushed and manipulated. Other questions that we typically get are, can this medication be mixed with medications? I mean, with foods. So different things like dairy can't be mixed with medications, such as like fluoroquinolones or levothyroxine. Like those things cannot be mixed in dairy. So just like having that background knowledge will definitely help us all work as a team. And when it comes to feeding tubes, I know a lot of these kids get to that point where they can't advance with their feeding when it comes to like swallowing therapies, and they can't have thickener. So we have to go to that point where they'll need like a G tube or a GJ tube. So that's always a question that we'll get to, like, can it be given via the G tube? Is it absorbed via J tube? Will it adhere to the tubing? Will it crack the tubing? So one of the craziest things, and this was like a horror story that I'll never, ever, ever forget. Like I'll remember that a medication such as Epidiolex can't really be given via certain feeding tubes. So if it's a polyurethane feeding tube, do not give Epidiolex, because it'll crack it and surgery will get really mad at you, because then they'll have to replace the tube and it just advances the care so much more. So just like knowing all those background things, I definitely will help us all work as a team. Justin, do you have anything to add? Because we've dealt with the same populations, like all of these CP kids and just developmentally delayed kids that just can't swallow.
Well, one of the other things that I think about, Mary, are kiddos who may not have a formal diagnosis of dysphagia, but they simply have trouble swallowing pills. And maybe we don't have a way to compound them, and they only come in these solid oral dosage forms. Mary, have you ever been involved in doing pill swallowing teaching at all, or making kits for that?
I personally haven't. This is where I would lean in and either ask our SLP on the floor or Child Life, and they have these cute little kits where they would help the kids like learn to swallow based on like the different sizes of things, and they would advance as time went on. What about you, Bree?
Yeah, I was going to say a lot of times when that happens, there's certain strategies that I can provide, but sometimes that I have found that with the older kids that it happens with, it's more of a psychological component to the swallowing of it. And so sometimes we do need to seek support from a psychologist as well to kind of help the child work through it. The other thing that I will say is that I've also sometimes found that if the child is in a position where cognitively they can understand the importance of the medication, sometimes that internal motivation of understanding this makes me feel better helps them overcome that as well. So again, kind of like those feelings of like self-efficacy, right? Like I want the child to understand like you can do this. And if they understand the reasoning behind it and they're motivated enough for it, a lot of times that will also help. So sometimes just sitting and talking with them to really understand, like, do you understand what this medication's for and why it's used and what it does, and kind of helping with that side of it, because there are some medications, and I can speak from personal experience. I did not swallow a pill until I was like 18 years old. I was so in my head about it. I'm like, I know I swallow pieces of food significantly bigger than, this little tiny pill, but it was just super psychological. Now, because I've had to be on different medications for different things, like I can take like 4 pills at a time and it's no problem, but I understood the why initially to kind of get me past there. So sometimes like sitting and talking with the patient about understanding that why, but I do find in those cases when they don't actually have dysphagia, it's more psychological in nature at that point.
I think we have a little guest star. We have one of our pharmacists, Brian, on the line too, and he brought up a great point. Brian, do you want to chime in?
Sure. One of the things that we've had happen when we've had to drop NG tube, or it's more like NJ/ND tubes. So my background's more hemonc, and we forget that, hey, to make these suspensions taste good and actually get swallowed, we add a lot of sugar and sugar alcohols and flavoring to it. So the osmolarity increases, which when you're swallowing it and you have that normal process, it's going to be diluted. Your stomach can handle a higher load. But when you put those right into the jejunum and duodenum, it's not designed to handle that. So you've essentially created a laxative with that suspension, and have had a lot of babies post-transplant that all of a sudden would cause diarrhea, and we're working them up for GVHD and is there adenovirus, all these other things. And really at the end of the day, we looked like, hey, we just didn't dilute these medications enough, or can you switch to a different formulation to bypass that?
Yeah, Brian, that is a great point. One of the other things that comes to mind, and this is more pragmatic. So for those of you who are listeners and parents, an encouragement would be related to the psychological aspect of pill swallowing. Be careful not to shame your kids for not being able to swallow these pills because of the psychological aspect. Comments like, well, you can swallow bigger pieces of food all the time. Like, why can't you do this? That can be defeating for a young person. And so instead, maintaining that patient, encouraging attitude toward kids and really giving them the tools that they need as well as the social support that they need is way more effective. So our attitudes, as has been brought out through the podcast towards kiddos, even for things like pill swallowing, are so important. Well, as we land the plane here on our podcast for today, I'd love to give our guests just a couple minutes to relay any take-home points they want us to know about pediatric dysphagia. So, Bree, I'll start with you, and then Brooke, we'll let you add in anything you'd like to as well. And Mary, we want to hear your thoughts too here at the end of the podcast.
Yeah, I kind of have just like 3 quick things that I want to reiterate. One is that be aware that dysphagia symptoms are not always classic coughing with swallowing. There's a lot of other aspects that we need to consider, which kind of goes into my second point I want to hone in on, which is when in doubt, refer out. If you are concerned that a patient is having difficulty at any stage of feeding and swallowing, go ahead and make that referral for the comprehensive assessment. And then the last thing that I would just encourage all providers who are listening is to never stop learning and always question your practices. I'm sure Brooke and I would both say, if you talked to us 5 years ago, 10 years ago, we probably would have told you a couple things that are different. And I just always want to encourage people to say, like, always continue learning and change your practices as science evolves. And that's really important for patient care.
Yes, I agree with everything that Bree said. And I kind of hope that 5 years from now, we can listen to this episode and say, oh, things are different. So I agree with that. And I'm going to add in something I've already talked about a lot on this episode, which is that this is a huge, that teamwork is a huge critical component of identifying and treating, managing dysphagia. And the team can be huge. It might be speech pathology, occupational therapy, pharmacy, physical therapy, physicians. And I don't want to minimize the importance of the persons at the center of the team, which is the patient, the kid, the client, their family, their support system. That is the most important part of the team. And I think sometimes in healthcare, we think about teamwork as being interdisciplinary, which it is, but we can sometimes forget that the person and the people at the center are the people that we are caring for. So we are here to help coach and manage and things like that, but really focus on the patient, the client, the kid, the family, and really truly take a team approach.
And I think I would also piggyback on that. Just the theme of this paper and everything, like dysphagia is the silent enemy. It's something that not many people know about and not many people know to screen for, but it's something that'll change a person's quality of life tremendously, whether they're an adult or they're a child. So really taking a team-based approach and just leaning in on everyone's expertise, I think is the greatest way to treat this disease.
Well, we are so thankful that you've all selected to join us today and talk about this important topic. I know I've learned a lot. I hope you guys as listeners have learned a lot too. So Brooke, Bree, Brian, we thank you for your input. And Mary, it's been an absolute pleasure. Thanks for joining us on the podcast.
That's all for today's episode. Thanks for listening. And remember to subscribe on Apple Podcasts and leave us a review.